The microsystem I've chosen to talk about is in an acute care hospital in the Greater Bay Area in California. It is a 40-bed unit and it has direct patient care to surgical patients, trauma patients, patients that require step-down or progressive care, and cardiac patients. We have registered nurses and CNAs that do team nursing on the floor, as well as a lead or relief lead, our manager, and the director. Our leadership at the manager, director, and administrative level is linear. Staff is rarely included in the information or decision processes involving large decisions. Recently, there was a merge between two units, and the staff members were not involved in the decision making, and they were kept out of the loop. Managers and directors knew approximately 9 months to a year before the merge was going to be involved, but the staff members had 2 months notice that they were going to be joined with another unit. It took the surgical trauma unit and the step-down unit, who can take care of each other's patients, but there was minimal training involved so that they were comfortable taking care of the other sort of patients on a daily basis. The administrative people and the directors also have long-term fixed strategic planning. They have a plan of taking the hospital and going in a certain direction without stopping to look at what's going on in the microsystems. The hospital wants to become a Trauma 2 level hospital after becoming Trauma 3 a year ago, and the influx of patients has created a stress on the microsystems. The unit has been understaffed, but even though we don't have enough staff to take care of the patients we currently have, they're trying to add more services so that we can take on more patients and get more revenue for the hospital. There's also a preference for yes men in this microsystem. Managers have told the leads or relief leads that they need to be positive when talking to the rest of the staff, and that they need to have a can-do attitude despite all of the anxieties that everyone was feeling. They also have a plan, organized, controlled, direct management. Instead of being involved and being on the floor with the staff members, they plan everything out, control and direct it. One way that this microsystem has demonstrated its organizational culture is with the use of our resource nurse. It used to be that the hospital would place a nurse on work standby if they did not currently need the nurse but thought that they might need them throughout their shift. So the nurse would stay at home and have to be able to come into work within 30 minutes of them calling if needed. However, some people live farther away from the hospital than 30 minutes, or the staffing needs of the unit would change so quickly that we wouldn't get staff when we needed them right away, or it was a waste of money for them to come in. So instead of having the work resource, they started having a resource nurse, and it was a luxury to have a resource nurse instead of having it planned into the budget. When the administration saw that the inclusion of the resource nurse was decreasing overtime for nurses, and it was also leading to greater satisfaction, they let us place it into our budget as a trial. And as per policy, when they created this new role, they said that the resource nurse was only required to give nurses breaks and do any other duties as assigned. As the role developed, the resource nurse began seeking out more responsibilities in order to expedite patient care, increase patient safety, and improve patient outcomes. The hospital and this microsystem uses Gene Watson's theory, the philosophy and science of caring, as its nursing theory. It also utilizes relationship-based care as its professional model of care. From this theory, they have created our professional practice model, which includes evidence-based practice, professional development, transformational leadership, care coordination, resource allocation, shared governance, meaningful recognition, and exemplary outcomes. They also included North Bay's values in our professional practice model, which includes respect, excellence, teamwork, integrity, stewardship, and community. The interdisciplinary team works together in order to achieve optimal patient outcomes. We have hospitalists who take care of patients' medical needs. We also have surgeons or interventionalists, our registered nurses, CNAs, case managers who also work with discharge planning, social workers, and our physical therapists, occupational therapists, and speech therapists. We use technology in order to help improve patient outcomes and maintain patient safety. We use an electronic health record in order to have easy access to the information of the patients. We're also going to be starting to do barcode medication administration to decrease medication errors. We use a Cerner station for medications. The Cerner station has medications already loaded into it, so once the physician puts in an order for a medication, as soon as the pharmacist is able to verify the medication, it becomes available for the nurse to take out. We no longer have to wait for the pharmacist to be able to deliver the medication to us. It decreases the time we need to wait for stat medications or routine medications, and it also increases patient satisfaction. Another way we use healthcare technology is by the computer physician order entry. The physician is required to place their own orders into the computer, and so there will be no issues with legibility of handwriting, and the physician can put in exactly what he wants instead of having it go through the nurse. There are several different ways that our microsystem attempts to improve upon itself. We do have a department-based council, and we have representatives from our unit. We have a role called a clinical nurse 3, who takes on additional responsibilities and acts as a resource for the other staff members on the floor. There are several different areas that someone can become a clinical nurse 3 in education or wounds or cardiothoracic, and they just have a little bit of extra training in order to help the other staff on the floor. The other way that our microsystem tries to improve itself is by using unusual occurrence reports. We fill out reports on any issues that occur, any mistakes, any errors, any near misses, and then that goes to our performance improvement department, who then puts data together in order to work on whatever issue they find in the system or in any other area. Management uses several performance markers to keep track of staff performance. We use the HCAHPS scores, the surveys that go out to patients. Patients fill them out about their patient satisfaction, about their perception of their services, and those scores are then brought to the staff in daily huddles. We also use core measures that are tracked, um, and those would be pneumonia, heart failure, or myocardial infarction. If there was one thing that I would change about this microsystem, it would be the leadership. A change in leadership going from a linear to a complex would help the morale of the staff. And a staff that feels like their work is being supported will be more productive, producing optimal patient outcomes. For one thing, the staff needs to be included in major decisions. The decisions that are made for the unit are made by people who are not in the front line and who are making decisions for an area that they are disconnected from. I would also make the information flow easier between staff and management to open that line of communication. Leadership would need to be delineated, and there needs to be a better show of support for staff. In order to form the change in leadership, leadership and managerial staff would need to be trained in complex and gain leadership. They could have a workshop or some other avenue to get them to start thinking in a complex sort of way. A lot of the staff have little communication with the manager or with our director. I would implement open office hours for staff to make appointments with the management. This way, if there is an issue, people would feel like they could come to the manager and have that open relationship. Working 3 to 11, I rarely see the manager. I don't know what she's thinking. I don't know where the unit is going. There are staff meetings that are once every quarter, but the information that is given is not enough to really know what our unit is working towards. There's also a suggestion box, but it's not used effectively. They take the suggestions to the department-based council, and if they have time to get through them, they do, and if not, it gets pushed back. I think that they could use the office hours and the suggestion box together to actually talk about whatever suggestions the staff has and maybe create something out of it. Because the staff are the ones who are on the front line. They're the ones that really see the day-to-day operations and how things flow, and they might be the best ones to have the ideas for improvement. I would also increase the visibility of management for all shifts so that everybody feels like they are supported and that they have a voice in their organization.